Good morning, everyone. I think we're on. And are we broadcasting for Zoom also? Okay, fabulous. Good morning. We'll go ahead and get started since it's 7:30 and we don't want to waste a moment of our grand rounds today. I'm so excited to introduce Stephanie Leonard, who is joining us on the faculty. In fact, as of December 1st, she'll be an assistant professor. She's currently an instructor, and we're thrilled to have you with us, Stephanie, as part of the department and also the Dunlevie Center. Um, to start with, Stephanie began at um, at Cornell, where she majored in human biology, health, and society with a minor in global health. I mean, she had a long trajectory. You'll hear this through her history that really led her to today. She then went to UCLA, where she did a master's in epidemiology with her focus on pregnancy risk factors for preterm births in the Hispanic population. Followed by a PhD in epidemiology at Berkeley, where she studied pregnancy weight and weight changes with infant and child health and arriving to us eventually as a postdoc, where she studied severe maternal mortality, morbidity, predictors, trends, and disparities. Um, we're You also have received several different routes of funding through the MCHRI, where Stephanie worked on disparities in sexual and gender minority family building, as well as opportunities to improve inequities for pregnant people, and wisdom funding, where she studied SMM risk prediction index. Stephanie, you've been an investigator, collaborator, mentor, teacher with focuses on pregnancy health and health equity. We are thrilled to see what you're doing today, which is actually directed more at teaching, and then we'll have you back to share your findings in severe maternal morbidity over time as well. So thank you very much. We look forward to.
So much. Okay, great. All right, good morning, everybody. It's really nice to see lots of people here in person, and thank you for joining via Zoom. I think I really lucked out with the date today. I didn't realize it was going to be the first day of standard time, so I hope we're all a little more awake than normal. I appreciate it. So thank you for the great introduction, Dr. Subak. I think as I've met many people here, I've been an instructor in the department for the past 3 years and senior biostatistician. And a lot of my role, in addition to my own research, has been supporting and growing our study design and conduct among investigators in the department, in particular, growing a biostatistical core to support that work. And so when I was asked to give grand rounds, I thought that maybe the most useful thing to do would be to give a talk that was inspired by a lot of the conversations I've had over the past few years with investigators who want to design their study, and then also how they're going to design and conduct their analysis at the end of the study. So I know there's a wide range of backgrounds in this topic area, and so I hope that this talk kind of goes broad, but then also goes deep in a few areas so everyone gets something out of it. So here's the outline of the talk. I've structured it around the 3 major sources of bias in studies, which are selection bias, measurement bias, and confounding bias. And then I'm going to bring it all together with introducing target trials, which are a method in observational research to minimize these forms of bias. Specifically, towards perinatal epidemiology and studies, I'm going to mention live birth index bias, a controversy around ongoing pregnancies as a denominator, and then a measurement bias, differentiate non-differential and differential bias, and confounding, I'm going to focus on methods to address confounding at the time of analysis. And then again, I'm just going to end it with talking about target trials, which are a framework. Throughout the talk, I'm going to use causal diagrams as one method to explain some of these concepts. So if you aren't familiar with these are often, the specific kind of causal diagram is called a directed acyclic graph, or a DAG. This is the most simple form of one. You have an exposure or a treatment, A, and then you have an arrow that points towards your hypothesized outcome, Y. And then these can get more and more complicated, and we use them as a method, very, very regularly for planning all studies, to think about causal inference and how an exposure causes the outcome. And what this is embedded in this, the question is, what is the probability of the outcome if everybody was exposed versus nobody was exposed? Or if this was a continuous exposure, you could think, what is the change in the probability of having this outcome for every unit increase in the exposure? An example question would be, what would be the change in postpartum blood transfusions if no patients had antepartum iron deficiency anemia? Or as a continuous exposure, what would be the probability if there were antepartum hemoglobin increased by 1 gram per deciliter? And this is a real actual study that people in our department are working on. However, we can never observe what are called these counterfactual scenarios where everyone got the treatment or everyone didn't get the treatment. And so this is really what clinical research is often trying to answer, is how can we best emulate this counterfactual scenario? So as I mentioned, I'm going to structure this through the 3 major types of bias. There's lots and lots of types of bias in study designs, but all of them can basically fit into these 3 buckets. And so the first is selection bias. People are probably well aware this is bias due to your sample selection. The second is measurement bias. This is bias from the data being measured with error. And the third is confounding bias. That's when the effect of the exposure is mixed together with the effect of another variable. And we generally are not interested in that variable. We want to, wash it away from our causal inference analysis. So selection bias. Here there's a presenter saying, 99.8% of people in our study love responding to surveys. And we received 500 responses and found that people love responding to surveys. And this is obviously a silly example, but this happens a lot in more nuanced situations, not just with surveys, though it's certainly an issue with surveys, that we think we're seeing something really profound, and it's just an artifact of the selection, either into the study or out of the study with loss to follow-up. So some selection bias terms. So selection bias can affect internal validity and or external validity. So internal validity is when your research question is answered without bias. So we did a study at our hospital. It was perfectly done. We believe the effect estimate is true. External validity is that the findings can be generalized to other settings. We often call this generalizability. So maybe that was the correct answer and true effect in your hospital, but maybe it can't be replicated at other hospitals and isn't true for the broader population. That would be an external validity issue. For today's talk, I'm going to focus on internal validity for selection bias. So I'm just showing a long list here of different types of selection bias and terms people use. I'm not going to go through them, but you probably are aware of these different ones, just to be clear that so all of these can kind of fit into different selection issues. I think the most common ones that we come across in our research are non-response bias, which is like kind of survey design, and loss to follow-up bias. So here is selection bias in a simple DAG. So again, like in that earlier slide, you have an exposure A, hypothesized related to an outcome Y. And then at the bottom now we have a person who's included in the study results. And the brackets mean that we've selected for them. And you can see that if being in the study is affected by the exposure or the outcome of interest, that has induced the selection bias. And I just want to emphasize that it's not just who is in your study, it's not just who agreed to participate, it's also who was followed up and who was stayed in the study, because that ends up being in who's in your study results. So those are kind of the 2 fundamental parts of the selection bias issue. Now, specifically, people might be aware of something called live birth bias. And so I'm going to describe that if you haven't been familiar with it before, and then I'm going to talk about some methods to deal with it in analysis. So this is a type of what's called left truncation bias, and it's really common in studies of exposures during pregnancy. So as we all know, we have a timeline that starts at conception. Some of those proceed to live birth, and some of those proceed to childhood. So if we wanted to ask a question, which this is just a made-up example, but this has happened also in real life. So are antidepressants use in pregnancy related to an increased risk of autism spectrum disorder later on, ASD? I kind of used ASD because this has actually been criticized a lot for live birth bias, various studies for that outcome. But this would apply as well to pregnancy complications like preeclampsia and other outcomes that are, if they might be assessed among live births. So most likely if someone was doing a study about ASD, they would have a data set of live births. And so you can see here, where I put the brackets around it, they've selected for live births. However, if, say, the exposure, here we're going to say antidepressant medications, might also cause an increased risk of pregnancy loss or fetal death, that has induced this live birth bias. And so not everybody who is truly at risk of the outcome is included in the study. And so what should you do about live birth? And so yeah, then just to emphasize, so this is a type of selection bias because you're selecting out people who should be in the study based on the study question, but are not observed or included. And this is really an active area of research. There's lots of papers still coming out about the best ways to deal with this. And when situations get more complex, how can you predict the direction of bias? So it's not completely clear and it's not always a problem necessarily. But what can you do? Number one is to measure and include pregnancy losses and fetal deaths when relevant and feasible. Often it's all we have to work with. The data comes as among live births. But sometimes people have selected out, but like excluded the stillbirth data, and that's not necessarily the best thing to do, and it's something you should at least think about before doing it. Second is just formulate the research questions appropriately. It's not necessarily bad, like I said, that you only have live births, but the research question, how I formulated it before, did not fit that live birth parameters. So I think that's also important. You can, 3, conduct sensitivity analyses, especially when the exposure is known to affect pregnancy loss or fetal death. So that's really the big one. If you know the exposure might be related to your outcome, but it's definitely related to pregnancy loss or fetal death, you should be worried about live birth bias. And if so, the best thing you can do analytically is to adjust for common causes of the outcome and pregnancy loss in the analysis. So in addition to your kind of normal confounders, you should be thinking about that as well. And then I'm going to talk about another type of selection bias that's very specific to perinatal research. And this is referred to, I guess, as gestational age stratified analysis selection bias. So we're all on the same page when we're talking about, relative risks and risks of the outcome. We're defining risk as the number of occurrences of the outcome divided by the number at risk of the outcome occurring. And there ends up being a lot of controversy and mistakes around that denominator. Who is at risk of the outcome occurring? And then at the bottom, you can see, you could think of this as a simple 2x2 table, and you calculate the risk in the exposed, the risk in the unexposed. You divide them, and you get your relative risk. So this part of perinatal epidemiology took off in regard to stillbirth measurement. So gestational age stillbirth measurement had a traditional approach, which was that you would put in the numerator the number of stillbirths at a given gestational age and divide by the total number of births at that gestation. So the example at the bottom is made up. Let's say you had 10 stillbirths during week 40 of gestation, and there were 9,990 live births. You divide those, and you get a probability of 0.001. So in 1987, there was this seminal article in The Lancet, and it really completely changed how we calculate risks and rates for stillbirth at gestational age specific weeks, as well as other outcomes that occur before birth, like labor induction and preeclampsia. And what Yudkin and colleagues wrote in this paper was that the population at risk is not the number of deliveries at a given gestational age, but the number of fetuses alive at that time. And this has become referred to as the fetuses at risk approach, or the ongoing pregnancies approach. So what you can see here is now we've switched the denominator to be the number of fetuses at risk at the start of that gestation, not the number of births during that gestational week. And so what they did in this paper was that they compared, if you use this traditional approach, which is now referred to as pregnancies delivered, versus the fetuses at risk or ongoing pregnancies, and you're looking at, say, in this example, stillbirth incidence at week 40, you see that in the traditional approach, the rate is double what it is using the ongoing pregnancies approach. And if in their paper using real data, they found that if you use the traditional approach, the highest risk of unexplained stillbirth is about 33 weeks as an early preterm period. If you use the ongoing pregnancies approach, it's at term, peaking at 41 weeks. So it's really completely different and extremely important for clinical care. And then also this has been shown to be the correct approach for many other events. I'm going to give one other example. This was work done by Erin Coy and colleagues. They were really focused on preeclampsia and gestational hypertension. And the same idea on the left, you can see where they used pregnancies delivered as their denominator. And it looks like the gestational age specific risk of preeclampsia is decreasing as pregnancy progresses. But when you switch to the correct denominator, you can see that really it's increasing consistently and peaking at post-term. And of course, so these biases not only translating to the bias risk, but then bias risk ratios and odds ratios when you're doing analyses. So then the question is, which denominator would you want to use if you were doing gestational age stratified analysis? And it's actually, you shouldn't always use the ongoing pregnancies. So there's some controversy around this. I'm going to show this is the opinion that Dr. Coy and colleagues wrote in their paper. I think for the first one, if it's an event that occurs during delivery, such as postpartum hemorrhage, it makes sense that your denominator is deliveries. If it's an event that could happen in any pregnant person, like stillbirth, preeclampsia, labor induction, the denominator should be ongoing pregnancies. The controversy kind of exists around what if it's something that can occur during labor, but almost always happens during labor. Then you maybe usually want to use pregnancies delivered, but it's not totally clear. An example would be placental abruption. So I think that's just something to be aware of and think about as you're designing your studies. Right. So now I'm going to move into talking a bit about measurement bias. So this cartoon is saying on the person on the left says, this is your machine learning system. And the person with the shovel says, yep, you pour the data into this big pile of linear algebra, then collect the answers on the other side. The other person says, well, what if the answers are wrong? And the other person says, you just keep stirring the pile until they start looking right. And this sounds silly, but this is really, I think, the black box that a lot of, not only machine learning, but a lot of analysis is. And we spend so much time focused on reducing confounding and sophisticated methods for that. But if the data going into that is not good, there is not going to be correct results, no matter what you do. But you can keep stirring it and trying new things, and you will start to see a signal. In computer science, you're probably familiar with this called garbage in, garbage out, or GI/GO. So if there's bad information going in, there's going to be bad information going out. And this is actually what I am personally most passionate about, because I think it comes up the most in this movement to big data. You know, I think for that, we don't really have as much selection bias, and we have tons of people and, you know, all births in the state included in your study. There's lots of kind of great methods now to deal with confounding, but the measurement error is something that you can't really identify easily, and there's no way to deal with very well at the analytical stage. So what are sources of measurement error, which I think are important just when you're thinking about your study and maybe either how you're designing it or how you're interpreting the results if you're using retrospective data. The first is recall bias, of course. So if a participant does not recall data correctly, I think there's actually been an overemphasis on this. Lots of times people can recall their exposures very well if the questions are formed appropriately, but it's still good to think about. Hospital staff may not document correctly. I think it's good to remember that many people in the hospital system document data that we then use for research, and they did not document it for the purpose of research. So these include physicians, nurses, birth clerks, billing departments. 3, the data are not abstracted or transcribed correctly. 4, the participant does not use the prescribed treatment, so non-adherence. I'm going to put missing data in here. There's just missing data throughout your data set. And then lastly, the analyst may not analyze the data correctly. There's often errors in our code books. Sometimes there's reverse coding. There's been many papers retracted over that where the exposure is reversed. So there's just lots of opportunity for this error to occur. So what are the 2 main types of measurement bias? I think it's important to be aware of because the non-differential can be important, but it's definitely much less concerning than the differential type of measurement bias. Non-differential means, so you measure your exposure, there's going to be some amount of error, but if that's independent of the outcome, or and as well as your outcome is measured with some error, but that error is at least independent of the exposure. Versus in differential measurement bias, the error in the measurement is dependent on either the outcome or the exposure. And I'm going to show this in the next 2 slides. So here I'm giving an example of, say we're interested in, does prenatal ibuprofen use increase risk of having a congenital anomaly? And we're going to define that as a composite. And so you decide to ask people at their 6-week postpartum visit, did you take ibuprofen when you were pregnant? And then to measure congenital anomalies, you use the birth certificates where congenital anomalies are documented with some error. So what we're interested in truly is this A and Y, but then the A star is what you actually measure, and the Y star is what you actually measure. It's not necessarily so bad that those have some error, as long as you can see they're not independent. They're not touching each other with arrows. However, you could think that, well, maybe people with congenital anomalies are more likely to go to their 6-week postpartum visit. And maybe at that visit, they're more likely to have thought about what drugs they took during pregnancy because they've been Googling about causes of congenital anomalies. In that case, now the measurement error and the exposure is dependent on the outcome. And this is a much more difficult type of bias to predict the effect of on your estimates. And I'd say people often ignore measurement error. And I think the number one reason is because there was this famous paper like 70 years ago that showed that non-differential measurement error for binary exposures and outcomes biases toward the null. So I and many people here have probably written in their papers, we think there might have been bias, but it's probably non-differential. In that case, like our effect we saw actually is bigger in real life. So great. And that's okay, but I think that's really like helped people write off this issue a lot. The second is that I think this is just really difficult to identify and to remedy. And so what I hear a lot, I've written editorials criticizing this when people are using data that are known to be poor quality, and they say, well, this is the only data we have available, and so it's better than nothing. And I don't really necessarily know if that's true, but I think that's another argument that people make. And so I just want to mention a couple nuances on that non-differential before you write like this was biased toward the null. That assumption does require binary variables, so yes, no, exposure, outcome, and also that their measurement error are statistically independent. Second, you likely would have measurement error of your confounders, and studies have shown that this is a less predictable effect on your analysis, your outcomes. And yeah, this is still also an open area of kind of research on how to best handle this in analysis. The best thing you can do is to try to prevent measurement error. Like I said, probably avoid participant recall when it's possible. I think these quality improvement initiatives for improving clinical data documentation are extremely important. Here's an example here of one in the state of California that was partnered with CMQCC for OB coding for ICD-10. This is not done throughout the country, and I think is something that really has a lot of power because we use a lot of these data for research throughout the country. Also having qualified data abstractors who are using consistent approaches if there's multiple people, using data checks, supporting use of prescribed treatments and measuring usage if you're doing a trial, collecting complete data as much as possible, and then documenting the data correctly and doing coding checks at the analysis stage. So having like someone check the analyst code in case there's any errors there. So you have a data set and there's already measurement error in it. What should you do? I think as best as you can, try to use validated data sources, use validated questionnaires. If you can't do that, try to conduct a validation study. You can even do this, we do this like informally in a subset of the participants, say. You can also do bias analyses if you know what the measurement error is. So you can, as a sensitivity analysis, say, the truth is somewhere in this range. Also thoroughly check the data for inconsistencies and exclude the implausible values. All right. All right, now I'm going to spend a little bit of time on confounding bias, which is kind of the most famous bias, I'd say. So in this cartoon, the presenter in statistics class is saying if you don't control for confounding variables, they're going to mask the real effect and mislead you. But if you control for too many variables, your choices are going to shape the data and you'll mislead yourself. Somewhere in the middle is the sweet spot where you do both, making you doubly wrong. Stats are a farce and truth is unknowable. See you next week. And this is kind of a joke, but it's often true. I think people are like, how, I got to control for these, but then you're telling me, no, that's too many, but how many is too many? There's not a right answer to that. So I think there's validly a lot of confusion around how to deal with confounding. So using the DAG, again, so I think lots of people know what a confounder is, but nonetheless. So now we're going to have the similar study idea. So did someone take ibuprofen prenatally? And now specifically, maybe this congenital anomaly of the cardiac defect of PDA. And we can see that we could think that maybe infection with a fever during pregnancy is a confounder. And I've put the W, the confounder, to the left because it's very important that it's temporally the first occurring event. So if someone had an infection with fever and that prompted them to take ibuprofen, but separately that infection maybe caused the PDA, that was like that's a confounder. So there's basically 3 criteria. The first is that the confounder is a risk factor for the outcome, like you see here, the W to Y. 2, it's associated with the exposure in the source population. We see here with the W to A. And the big one that's often overlooked is that it's not affected by the exposure or the outcome. And just so you know, the reason for that is, like I said at the beginning, a confounder is really something we're not interested in. We want to get rid of this like confusion that it's adding to our causal inference question. However, if it was something that is caused by the exposure, that's really part of the causal pathway, and you want to think about that differently and not block it and take it out of the estimate. Confounding is the primary reason we do randomized trials. So if we did this as a trial, you can see that you just remove that arrow from W to A. And so now our exposure is allocation of prenatal ibuprofen. We assign half the people to take it, half the people not, and we measure the outcome PDA. Whether people had infection with a fever should be balanced between those two groups and is not causing people to take ibuprofen in this pretend scenario. However, there's lots of downsides. Trials are great, there's lots of downsides. Probably the biggest one, I think, is that trials tend to maximize internal validity at the cost of external validity. So unless you have the ability to do a very large multi-site trial and include lots of people, it tends to answer the question, the truth, very well in your hospital, say, but doesn't have what's called transportability to other populations. Second is trials are always going to be more limited in sample size than observational data, pretty much. There's always going to be feasibility limitations, high costs, ethical concerns. And trials still are subject to bias, like non-adherence to allocation, loss to follow-up, and other sources of bias. So if you're going to do an observational study, what should you do about confounding? And there's 3 steps. The first, identify the confounders. 2, collect high-quality data on the confounders. And 3, adjust for the confounders in analysis. And I'm going to go through these with specific recommendations. So first, identify potential confounders using causal diagrams. The current preferred method to identify confounders is to a priori formulate your research question and think about what your confounders are, often using like these DAGs. This is a real DAG that I made a couple weeks ago for a real study that I'm doing. I like to use this website that helps you also figure out what's a confounder, what's a mediator. It's called DAGity, but there's lots of other ways to do this. And you then pre-specify those and use those in your analysis. There are other methods people are likely familiar with, like stepwise selection or backward selection or change in estimate approaches. Those aren't wrong. I would say they are less in favor these days than using the a priori DAG approach. And then just to remember, the main thing is to not include variables that are affected by the treatment or the outcome. The second thing to do is really related to the measurement error. So collecting high quality data on the confounders. If you're going to do a prospective cohort study, try to ensure that you're recording detailed data in a systematic manner, assess the validity of the variables abstracted from the charts. And this can help with adjustment later on. In retrospective studies, so the data already exists, you want to assess the validity of the variables or find validation studies and consider possible measurement error. So you have confounders, you've identified, you have the data on them. There are various methods, a lot of different ways to deal with confounders in analysis. I think these can be grouped into 3 different approaches: restriction, adjustment, matching, and weighting. Restriction, as is pretty self-described, is when you restrict the number of people who are in your study. So say, to go back to our example of prenatal ibuprofen and PDA and confounding by infection with fever during pregnancy, say this was we already collected the data, and so we decided to just exclude any people who had an infection with fever before they started taking ibuprofen. I don't think this is the best way to deal with this confounding in this scenario, but just as an example of what it would be. You see this a lot in perinatal research of selecting to singletons, for instance. People tend to do that restriction a lot. The second one is the one people are likely most familiar with. This is adjustment. It's also called outcome regression. This works best in large sample sizes. And then as a refresher, if you have a continuous outcome, this generally means a linear regression. You might need to log transform the outcome or something similar. And then I put on the bottom, I also sometimes want to just remind people this is not super complicated necessarily. The fundamental part of it is a bunch of points and you fit a best fit line and you get a y equals mx plus b equation, and we use that to come up with the effect estimates. And then we have multiple linear regression on the right at the bottom. All we're doing is adding an extra term for each confounder that you're interested in. These can get more and more complicated, but that's essentially what linear regression is doing. And there's different ways to fit the best fit line, but still all kind of the same in the end, I think. So if you have a binary outcome, this is most common in studies that I've been working on. So a yes, no. If the outcome is rare, it's so say less than 5 or less than 10%, generally recommended to use logistic regression, which is just like linear regression, except we're modeling the probability of the outcome different. It's the inverse of the log of the outcome. And the reason for the logistic regression largely is because there's a bounds of 0 to 1 on the probability. So the value can only take 0 and 1. If the outcome is not rare, it's recommended currently to use a log binomial. So it's a log of the outcome, or a modified Poisson regression. And this isn't, and the reason for that is that is a better estimate of the risk ratio versus the odds ratio for common outcomes. And then just to mention, if you work with people in social sciences, they're probably going to tell you to use a linear regression or a probit regression for outcome. And this is fine too. It's really, I think this is a lesson of there are some wrong answers, but there is not a right answer. So there's different approaches you can take, you interpret differently. We tend to, just people in medicine don't use those. So we're not used to seeing them. And then finally, if you have a count outcome, you would use Poisson regression, or if that is called over dispersed, you use a negative binomial regression. So that's that for regression. Matching. So people ask a lot of questions about matching. This is, of course, a statistical technique where you want to create a comparison group that has similar characteristics. So you can see here, say we have a patient population with a bunch of green and orange people of different sizes, and we kind of match them based on their, so the green is, say, exposed and the orange is unexposed, and we match them based on their size. So this is something, you could do. You could actually physically match people on age or something at recruitment, but more commonly is that you want to match on multiple characteristics, maybe even 100 characteristics, and it's impossible to do that directly. And so what is recommended is to create what's called a propensity score and then match on that one score. And so what a propensity score is the probability that a person was exposed based on their observed characteristics. This is exactly the same as the outcome regression, except this is exposure regression. The outcome in the equation is the exposure. And then you can create a predicted probability for that. And here's just a graphic of showing how it works. In this scenario, they're interested in people enrolled in a program versus not, and they've estimated the propensity scores for those people. And then where it's dark gray, where there's overlap in those distributions, those are the people that are actually in the analysis. Those are the ones that get matched. The ones that are light gray, they don't have a match. They're kind of outliers, if you will, and are excluded from the analysis. These are the steps. So it's not necessarily super complicated, though it is computationally intensive. So you decide on the covariates. You do generally logistic regression to get the propensity scores. Like I said, the outcome now is the exposure regression. Then you match the exposed and the unexposed on their propensity score. There's a lot of different ways to do this in stats programs, like nearest neighbors is a common one, finding points that are near each other. Then you want to check the balance and the matching success. Sometimes this is a great method. All of the people who are exposed have a match. Sometimes none of them do, in which case this is not a good option to do. And then you just estimate the effect in that matched cohort. So this is now, many people think a more robust way than outcome regression to control for the measured confounders. And to emphasize, this is not a method to adjust for unmeasured confounding. That's still just measured confounders. And the last one people are probably less familiar with but is now probably the most common in causal inference, is weighting. And the idea here is to balance characteristics in exposed and unexposed groups by giving each data point a weight. So in this simplistic graphic, we have 4 blue people and 1 red person. We calculate and apply weights, and we upweight that red person. This is most commonly referred to as inverse probability weighting or inverse probability of the treatment weighting. And it's pretty similar to propensity score matching. You still estimate the same propensity scores, but instead of matching on them, you weight the outcome regression model with those propensity scores. And it's really like you just run the model and you put like weight equals propensity score. So this is really useful when you have more than 2 groups because you can't really match well with 3 or 4 groups. Like I said, if there's poor overlap in the matching, the groups are too dissimilar. or what you have measured, or you have censored data. So people have not had the event before the end of the data collection. And then lastly, I'm just going to mention quickly that doubly robust methods are really like the premier method supported these days. And this is when you combine an outcome-based method, so the logistic regression for your outcome, and with an exposure-based method, so the propensity score or the matching or inverse probability weighting. And the idea is if you do both of these, it's been statistically shown that if one is correct, your estimation is correct. So it's kind of like a way to bolster your results, that even if you think that it's a better chance that at least one is hopefully somewhat correct, even if the other one is completely wrong. And the simplest form of this is really not complex. It's that, so say here on the left, we have your typical outcome regression, a logistic regression for your outcome of PDA. On the left, we have this exposure regression, the propensity score. Your outcome is prenatal ibuprofen use. You just do both of those and you put them together. And that's the doubly robust method. Okay, so with the end of the talk, I'm just going to introduce quickly the target trial framework. So a target trial is a structured approach to conducting an observational study, particularly with big data, that emulates the ideal pragmatic target trial. This is also called target trial emulation. And it was written about in this original paper by Miguel Hernan and Jamie Robbins about 8 years ago, or 6 years ago, sorry. And to me, this is kind of like playing pretend in medicine, which as a parent makes me think of Doc McStuffins, which is the image here. So you're really like truly playing pretend of like, if I could do this ideal trial, how would I structure it? And that's how I'm going to structure my analysis of this existing data set. This target trial framework has really taken off, particularly in comparative effectiveness studies. Like I said, that paper was in 2016. It's had over 1,000 citations. Regularly, papers are coming out in New England Journal of Medicine, Lancet, BMJ, that are using this target trial framework. And particularly with COVID, I think that has really taken off since we have a lot of big data and trying to figure out the best way to use it. So I know there's a lot on this slide, but I just wanted you to see that this is the table you basically fill out when you're thinking using the target trial framework. There's 7 components. So like you would do if you're designing a trial, except now you just have observed data. So there's eligibility criteria. Who's eligible for your trial at enrollment? The treatment strategy. What are you going to assign treatment to your participants? The assignment procedure. What potential confounders do you want balanced between your 2 groups, your treatment groups? Follow-up. How long are you going to follow up your participants after they get their treatment assignment? The outcome. What's the outcome of interest? What's your causal contrast of interest? This is either the intention to treat effect or the per protocol effect or both. And then your analysis plan, essentially how are you going to adjust for confounders? And in their original paper, I'm just going to use their example because it's relevant to gynecology and women's health, is the effect of postmenopausal hormone therapy on the 5-year risk of breast cancer. So we think about and this is saying an existing data set. So we have eligibility criteria. We're interested in patients within 5 years of menopause between 2005 and 2010, no cancer or hormone therapy within the past 2 years. So this is very specific. It's giving exact years, time frames. I think something that people often overlook when they have big data. The second is treatment strategy. They're either going to 1, refrain from hormone therapy, or 2, initiate estrogen plus progesterone therapy at baseline and remain during follow-up unless DVT, PE, MI, or cancer occurs. Assignment procedures, open label random assignment to either treatment strategy. The follow-up period from allocation of the treatment strategy to diagnosis of breast cancer, death, loss to follow-up, or 5 years after baseline, whichever is first. That's would be typical in a trial. Outcome, breast cancer diagnosed within 5 years of baseline. They're interested in the intention to treat effect, and then the analysis plan, you're going to adjust for these pre-specified baseline confounders. So it sounds pretty simple, but actually it's a really helpful guidance to designing your analysis and these data sets. And so to kind of bring everything together, I'm going to give a quick example of using a target trial framework by thinking about labor induction, which is a kind of hot topic in obstetrics. So, and this example is not the same, but it's based on this paper in the Green Journal by Gibbs Pickens et al. So we might ask, so there's this ARRIVE trial, as everyone here is probably familiar, happened a few years ago where they randomized people to get elective induction of labor at 39 weeks or not. That was among nulliparous, generally healthy people. Say we're interested in, is elective induction at labor at 39 weeks associated with cesarean birth among people with high BMI, a specific patient group? In this study, they really used linked California birth certificate, fetal death certificate, and patient discharge data. So we could think about what's the eligibility criteria. We want patients who are pregnant at 39 weeks, 0 days gestation, without a prior cesarean. They don't have a planned induction or cesarean. There's no contraindications to induction, and they have a BMI of 30 or greater. The treatment strategies, they're either going to get induction of labor at 39 weeks, or they're going to get expectant management at 39 weeks. And the assignment procedure, this is an open label. You can't, placebo blind people to induction. Random assignment to either treatment strategy at baseline. And also, we're going to stratify the randomization by parity, which is something you would do in a trial because there might be a difference with nulliparous and multiparous. And then I just want to mention, call out here when we're talking about live birth bias, this is patients who are pregnant at 39 weeks of gestation. We haven't restricted to people with live births. So this is taking care of that. We have assigned people to expectant management. That's the ongoing pregnancies denominator. We're not comparing this to people who delivered otherwise at 39 weeks. We're comparing it to people who just didn't get induced at 39 weeks. And so our follow-up period, this is going to be from, for induction to delivery is pretty short. And then outcome is mode of birth, the causal contrast, we're interested in intention to treat. And the analysis plan, we've pre-specified these baseline confounders based on a DAG, and we're going to do a multivariable log binomial regression model. And then to base that back to this measurement error issue, these variables that they chose in the study, as well as the exposure and outcome, are all known to have high validity based on prior validation studies. So that's really reassuring. And here's just 3 of many studies that have done validity on these birth certificate variables. So that's, I think, a reassuring part where they have thought about measurement error. And then last, like we had talked about, none of these in this list are affected by the exposure or the outcome. You can see in the DAG, elective induction does not affect someone's age or education, and neither does mode of birth. And so these are correct confounders. And so with that, I think, I'm kind of I want to leave enough time for questions. So thank you so much for having me. It's really wonderful to work with all of you. And please let me know any questions or suggestions for all of this. So thank you so much.
Great. Thank you, Stephanie. Thank you. I don't know if you can hear me.
Yeah, we can hear you and see you.
Okay, terrific. I'm not in the room, and so it's hard to tell who's in the room. I don't know if there's a microphone available, so we're going to do questions 2 ways. One is, okay, so if there are any questions in the room, please, if someone can turn the mic.
I can repeat them maybe, too.
Okay.
Either one.
Yeah. I have some for you from Zoom and from my own, but if there are any in the room, let's handle those first.
I think you can start with Zoom. What people think.
Terrific. Okay.
Yeah.
Well, thank you. From Ron Gibbs, this is a 2-pronged question, so I'm going to give it to you in 2 pieces. But he comments, excellent job. In view of recent discussions, how should race be handled as a variable?
Yeah, I get asked this a lot now, and I think the big thing is just to be thoughtful about it, is what I say. I think we're often kind of taught, well, adjust for age, sex, and race, ethnicity, and I don't think it should be grouped with those. I think there are times that it does make sense, and there are times that it doesn't. The same with stratifying your analysis by race. Ask yourself, do you really think this effect is different by race? And if so, why? Don't just do it because you think that it might be interesting and have an interesting result. And then also, if you do adjust for it, like you saw maybe in the DAG I showed, I specifically should put as a social factor. I think we just need to do everything we can to, if you think that this is representing racism, be clear about that. Because otherwise, if you just put race, people are going to interpret it as a biological measure. That's my thoughts on that.
Great. And then that leads right into the second part of the question is how can we measure racism?
Yeah, I mean, in the existing data sets, you're pretty much going to have race, ethnicity, and if people self-report it, that's generally that's the gold standard for race, ethnicity versus being categorized by someone else. I think there's a certain need for more research of people's experience of racism, and if you have that data available and are able to collect it, that's excellent.
Great, thank you.
Yeah.
And again, I can't see if there are questions in the room, so I want to keep going. But if there's a question in the room, I can handle that.
I'll let you. Yeah, I can speak up if there. Keep
going. Okay,
go
terrific.
Ahead. Yeah.
So you touched a little bit on the obstetric literature, and I think that this is really helpful. So I appreciate what you said. I've got a twofold question. One is, what changes would you like to see in the obstetric literature? Not just, I mean, we've got changes within literature overall, particularly based on, here's this 2016 study, and we can see how these things that, initially we think are sort of fixed really are not the way we think about, these just research questions and approach them. But one is just, what changes would you like to see most, or do you think most should occur in the obstetric literature? And then the second piece of that is really, I'm hoping you can comment more about propensity score matching, because that's been more of a recent thing in obstetric literature, and really, when should we be doing that in our own internal studies?
Yeah, great question. I mean, I think the obstetric literature, I would say a lot of the kind of causal inference methods really were not at all developed with obstetrics in mind. They tend to be developed with, these days, either COVID or cardiovascular diseases in mind. And so a lot of things I do think need to be adapted a bit, because I mean, pregnancy is very different. People who are pregnant are very different than a lot of the populations. For instance, like they're very interested in time varying exposures. So someone who, maybe or has like multiple outcomes, they have multiple heart attacks. That's really different than the kind of things you would think about in pregnancy. And so I think there's a lot of methodological work that's needed to adapt for pregnant populations. And your second question was about propensity score matching and when to do it. Was that it?
Yeah, I mean, it's something that the journals are more frequently asking for now. And it's, 10 years ago, I think it really just didn't, you didn't see that at all. And I'm wondering if you can just comment. It may be a new concept to some people in the room. And so
Yeah.
just wanting to kind of really reinforce, what is that again? And when should we be thinking about it?
Yeah, that's a great. Well, clearly the statistical editor at the Green Journal really likes propensity score matching. So that's to start off. Whoever they hired as a statistical editor just really likes that method. People tend to get really into one method or the other. It's not something that like universally all biostatisticians, epidemiologists are like, this is the answer. And there's still a lot of controversy about when it is biased or not biased. So I think it's just something to be aware of and know that you can do it. I think it is, it just really depends on if it's the best answer. For something that's like these huge data sets where we're using with millions of people, it often really doesn't, it literally computationally doesn't work. And it doesn't improve on the estimate. I think in some smaller ones with really imbalanced groups, it works really well. So I think you can try, I mean, what we tend to do in a lot of these studies is maybe do the outcome regression, which I think can work really well actually in these population-based data sets, and then do a propensity score matching as a sensitivity analysis. I mean, we've done that in maybe like 5 analyses, and they've been very similar. So that's just reassuring. In general, if you try like one approach and you try the other one and they're similar, that can make you feel really good about your results. But yeah, and it's not, there are lots of decision points in propensity score matching, but it's not super complicated. I think you can probably, if you can just wrap your head around the idea of instead of the model being for the outcome, it's for the exposure. That's really kind of fundamentally all it is.
Great, thank you. And then, we have a lot of trainees in the room, a lot of trainees who are on, and I think that, I mean, you've summarized actually a lot of very complex concepts very, very succinctly and nicely, but it can also be very intimidating when someone is new to research. So any advice to trainees who are thinking about research, and if you can comment a little bit about what sort of help is available or how one might approach just wanting to do a research project, having a great idea, and then, what do you do with it? Especially if you're a trainee.
Yeah, thank you.
One of our new residents, so.
Reach out to our research team early and often. It's great if you have like really just an idea. Like I mean, we have people like who email me or, that I was on service and this interesting thing happened. I did a literature review. There wasn't anything. Does this even seem feasible, or what should I be thinking about? The earlier we kind of have that conversation, I hope it's helpful. And I think has steered some really interesting, wonderful projects that residents and fellows and medical students have done that we've been a part of. And I think that, you certainly don't need to fully understand. I was mostly towards the end of this talk, particularly, I just want you to be aware, because often people are like, I read a paper and they mentioned propensity score matching, or they mentioned like these doubly robust methods or something. Just like, it's not, and if you look them up yourself, you tend to get sucked into this like statistics literature that I think is not very approachable for most people, rightfully so. So yeah, please feel free to reach out to us. We have like Dr. Subak and Dr. El Sayed and others have really invested in creating a robust research team that's happy to support your research and guide you as well to whatever amount you want to understand these methods as well.
Great, thank you. And when you say reach out to us, we've got your email here. Who else might they reach out to?
I would say just reach out to me and I would help direct it. We also, if you're familiar with an intranet with our department, and we have a forum on that, which if you want grant support or biostatistical support or just talk to someone, that's really great because now that our teams have gotten bigger, it sends a notification to all of us and doesn't get buried in our emails. So using the intake forum is really great. If you aren't familiar with it, you can also ask me about it. But you can also email me and I'll probably send you to the intake form.
Great. Thank you. And then one more, and I'm encouraging people to type questions, any other questions into Q&A as well, or ask in the room, but one more group to give advice to. Maybe somebody is new trainee and or not so new, but they really want to get more involved in research, but don't have the idea, but how might they join a project? What advice would you have for that person? They want to learn sort of the ropes of it, but it's, they're on ONC, they're on nights, they're on, so many different busy rotations.
Yeah, I mean, I think, there's a lot of understanding in our department that it's very clinically demanding trainee programs, and we're very flexible and understanding and try to have learning opportunities that work around that. If you could kind of reach out or talk to others, maybe who are trainees who are further along. We have journal clubs and we have other methods that we connect, and there's courses you could audit if you really want to. And a lot of those now are online, so you can do them on your own schedule. So I think those are a lot of the opportunities people can think of. We have, an MFM, we have research brainstorming. You can just show up and just listen and get some ideas and then reach out to people that you want to join their projects. I think everybody is extremely supportive and welcoming, especially for trainees, to join projects and be involved to the extent that they want to.
Great, and I would totally second that and agree. Are there any questions in the room?
I'll ask. Any questions in the room? I don't think so. We have I think we're okay. But please speak up.
Well, Stephanie, I want to thank you for just a wonderful overview and just great runarounds this morning. And I think we're going to give people a little bit of small amount of time back and say thank you all for your attention.
Yeah, thank you all so much.